Okay, now you know we're being recorded. So we're going to talk about Section GG stuff, some of the essential updates and reminders, as well as I'm going to show you some information that is specific to your facility. So you might find this kind of interesting in that regard. And as soon as I can get my slides to advance, I know that, are you able to see the full slide, or are you seeing images of each other?
I can see the slide.
Okay.
Except it says the meeting's being recorded in front of it.
Right, okay. Okay, does it block your view of what you're seeing?
People.
You're seeing people. I minimized the screen.
Oh, okay, I got it.
You can minimize the people.
Yep,
but that's why I'm glad that we can hear each other, so I won't see you flailing, because otherwise it does block the screen, and I want to record the best we can record, and this is kind of new technology for me. So we're talking about this again for those that may be new with us, that you haven't heard the spiel, but for those who have been, and that's the majority of you guys, we are bringing this topic up again for a lot of reasons, and one of the reasons being, and the others are not in any particular order, but it's kind of a rehab report card. How are we doing with getting people better? And this report card is being made public now on the Nursing Home Compare website. So if you haven't had a chance to look at the Compare website, it would be really interesting for you guys to see it for your facility. I'm going to show you a snapshot of some of the stuff it shows for a different facility within the Arbor family. But it would be good for you to know how you look to the public. And there are things that we can't control, and there's things that we can control. And part of it is our GG scoring accuracy, so that what gets reviewed publicly is the best it can be. So the other thing is that CMS is looking at where they're going to get the best bang for their rehab buck. And is it going to be with home care? Is it going to be in the SNF industry? Is it going to be inpatient rehab facilities? So they're looking at how much improvement do they get per dollar spent on the individual. And if we don't show a strong level of improvement per dollar spent on the individual, we're going to be left out of the mix when they're allocating funding and deciding who they want to support, where they want to spend their dollars. We're going to end up with the short end of the stick if we don't look like we're doing the good job that we're doing. So we really want to make sure that, and part of, again, this is reflected with our GG scores. So it's so important to get them as accurate as we can reasonably be. The other area is true story. You know, we all have that level of integrity. We're professionals, and we went into a helping profession. So is the information we're reporting telling a true story about the person? And I would hazard a guess that we're not consistently telling a true story, and it's nobody's deliberate, malfeasance or anything like that, but just, we're in a hurry and you're jotting down some numbers, and then it ends up, it looks like we're maybe not reporting things accurately. And the other concern that's coming up is, of course, always the Office of Inspector General. And again, those of you who have known me through the years know that that's our watchdog. Back when we were under the previous payment system, if some company had mandated every employee to provide 720 minutes of therapy for every person every time, the OIG is the agency that's stepping in and really penalizing. They're also now sharpening their pencils and looking at how they're going to audit and penalize the nursing home industry, because they were expecting, when PDPM kicked in, it was supposed to be budget neutral, meaning it wasn't going to cost the government any more money to run PDPM than it cost them to run the old PPS system. What they found is that the rates actually went up 5.3%, and they weren't expecting that increase. And they said, yes, we understand COVID happened, but COVID only accounts for 0.3% of the rise of that 5.3% increase. So I don't know how they did their math. I don't know who their statisticians are, because I find that rather interesting that it was only 0.3%. But they're saying the other 0.5%, they want to make sure that we are being accurate with our reporting and scoring, all the things that factor into the PDPM case mix score, which then impacts reimbursement. So we've got to be squeaky clean, because now they're looking at us since they had some unexpected results. Whether we agree or disagree, they're looking at us. We're going to be under the microscope again. So we need to make sure we support our GG scoring information. The claims need to be accurate, which we would absolutely try to do, but we absolutely need to make sure they are clean, because OIG is looking at them. It does impact reimbursement, and we need to be able to justify the money that we say we're eligible for or being reimbursed for. So the screen you see here is an actual snapshot of some of the information that's available on the Nursing Home Compare website. You can just Google Nursing Home Compare and it'll come right up. It's like nhcompare.gov, I believe is the site. Put in your facility name. It's easy peasy to get this information. They've made it very user-friendly. because we've got a generation now of adults that are placing their parents and know to look at all of these websites and these social media pages and all the information that's available out there to decide if they want to go to, Orchards of East Liverpool or Valley Oaks or something else that's down the street. So there, there was a time when this internet stuff didn't really much impact us because the generation that was using it didn't know how to use it, or could have used it, they didn't know how to. Now we've got, the kids, at least of the 80-year-olds, who are well savvy with using the computers and may well look at you guys through the nursing home compare site. So when you look at this facility for health inspections, they look pretty stinky. They didn't do well with cleanliness and that type of thing with their health inspections. They did a little bit better with staffing, but they are still below. They've only got 2 stars for staffing. They've got 4 stars for the quality of resident care. Okay, so what do you think this outcomes report, this nursing home compare report, what do you think it says about the facility? You guys can holler out. Do you think they have maybe decent rehab?
I would say if it's
Yeah,
quality
exactly.
of care is there.
Right, exactly. The quality is there. We can't control staffing. We can't control health inspections per se, but we can improve the quality of resident care. And some of the indicators are on this other slide here that's on this page. The percentage of SNF residents who experience 1 or more falls. This is the same facility. They are a little bit above the national average. You can see the national average is 0.9%. This building had a 2.2% rate of falls with a major injury. Percentage of SNF residents whose functional abilities were assessed and goals were made. They were about up there with the national average. Percentage of residents who were at or above expected ability to take care of themselves at discharge. Okay, this is prime OT stuff, is 54%, whereas the national average is 52%. Okay, and then the other measure that's down here, the percentage of residents who are at or above expected ability to move around at discharge. This building was at 53%. Again, the national average for this was about 54%. I know that's off the slide. So it's not directly GG information. It's not walking with 2 turns, but this data is taken from the GG resource. So again, this is where this is so important to make sure that we've got good, clear, accurate information so we look the best that is reasonable for us to look. As I said before, the OIG is one of the enforcement arms that will be looking at us in the days to come because PDPM cost more than they expected. This is from their OIG worksite, oig.hhs.gov, and it says down here in the bottom that the work plan for that was announced in April of 21 is that we will determine whether Medicare payments to SNFs under PDPM complied with Medicare requirements. They are going to be looking at us because, again, it was more expensive than they anticipated. So I want to talk about accuracy and errors and all that kind of good stuff. And I will say that overall, some things have improved, and I want to give you guys a shout out, because I do see less crosswalk errors. Crosswalk is we've got MDS terminology, we've got therapy terminology, GG scoring. So I call that's our crosswalk. And I do see less simple errors in that regard, but they are still occurring a little bit. So make sure you use the crosswalk. It's on our website. I can show you exactly where it is if you need to print off a copy. The buildings that I'm visiting live, unfortunately, I'm not getting to see you guys live, but I put that crosswalk on a copier machine and I shrank it down to just a little, I don't know, whatever, 2x3 or 3x3 image so that you could tape it right on the laptop. Because understandably, sometimes your head gets kind of swirly. You've got phone calls coming in, you've got family stopping by now, which is a good thing, but you can get distracted and you want to make sure you're scoring accurately. So consider making a little small GG crosswalk for the laptops of the evaluating therapists. Okay, I do see, again, better use of, for example, if somebody only went 30 feet, I'm seeing that scored as 88 for the item walking 50 feet with 2 turns. So I do see some better accuracy, but I will say that our MDS nurses aren't necessarily teaching people how to get in and out of cars. They're not taking them outside to walk on uneven surfaces or see if they can navigate up and down a curb. So if we're not the ones to teach and train on this stuff, who's going to? And there's people the people that we're doing GG on are oftentimes the ones that are going home or going to assisted living. So we want to make sure we're looking at this stuff because nobody's going to live in a bubble usually where they're going to never have to walk on a curb, never walk on uneven surfaces. I do know some of our folks that in the charts I've looked at, people are going home at a wheelchair level. So that does make a difference. But again, we have got to be the ones to be thorough and comprehensive with making sure we've taught the people everything they need to know to be safe when they get home. And we need to make sure that we're accurate with the GG scoring, because the nursing is probably going to take our scores on areas like car transfers, curbs, uneven surfaces, because they're especially not seeing that stuff like they might see with bathing or transfers or bed mobility. Okay. Another area to help us with being accurate would be to make sure that and have that supportive documentation for what we're scoring, is to use the breakout areas on the evaluation. So with physical therapy, for example, you can score overall bed mobility, but if you use the breakout areas in Net Health that look at rolling, supine to sit to supine, scoring that are it's just quick clicks, but it will give you supportive documentation for your GG scoring, so that if you say rolling is independent and you score them as a 6 for GG, and then for the other areas, you're scoring them as a 4. But when I look back at the eval and it just says independent, that doesn't make sense. You don't have supportive documentation. Why did you score supine to sit as a 4 when you said they were independent? So use those breakout areas to help with that quick accuracy, I guess we'll say. Make sure you're talking with nursing at the weekly meetings. Just like we used to talk, ARDs and minutes and that type of thing. Now we want to make sure that we're kind of coordinating our GG, giving them our GG information. They may do what they want to do with it, but we want to make sure that if we've got that information, that we share that with them. They know how the person's doing at midnight when they're trying to use the restroom. We know how they do at 2 o'clock in the afternoon with the walker, with the adaptive equipment for meals, whatever it might be. We need to be aware of what nursing is seeing at midnight or without the adaptive equipment, so that we can help that person prepare and plan for the times when they may not feel the most stable. What we see is only a portion of the day, and it may only be a portion of their true functioning. Are we addressing the whole person, how they need to function 24/7? So we need to talk with nursing to make sure we get that information. So we want to have the supportive documentation, as I mentioned, using the breakout areas. And then when we have discrepancies in our eval or in our discharge, make sure that you explain that. So for example, one of the questions that came up is if steps were initially a 9, they lived in an assisted living and they didn't have to go up and down any steps, and you rated them as a 9, not applicable for steps. That was the initial plan. And now the plan has changed and the family wants to take them home to live with them, and there are steps. You may well address steps. And so if that initial GG score was a 9 and their discharge GG score for steps is a 3 or 4 or whatever it may be, that's okay. But you might just want to explain that, discharge plan changed. Now the daughter's home with steps, and you want to make obviously a plan of care that includes steps with a baseline and all that kind of good stuff as well. So make sure you explain your discrepancies. Double check your entries for consistency with the eval or discharge GG scoring. I think what happens a lot is that, in your mind, you might be thinking, well, they're kind of contact guard, min assist, as you're thinking about the person. And so when you're doing the eval, you score them as min assist. You write down min assist in the body of the eval. But then, you go to walk down the hallway, you get a bunch of questions, you get a phone call, you have to go see somebody else before they get put back to bed. Now you have a chance to do the GG scoring. And in your mind, when you were kind of waffling on contact guard, min assist, now when you score them, you might score them as contact guard. But that's a huge difference. That's a discrepancy then, where there's going to be one area scored as a 3, one area scored as a 4, and we're not accurate we're not being congruent with our own documentation. Okay, so double check yourselves that you're being consistent with yourself. And I know that there's a lot of reasons why those errors can happen. The other error that I see in general is that we assume progress has happened and that they must need to bump up a score with GG. So for example, if they were contact guard initially and they improved to being supervision, yes, they did improve, but unfortunately the GG scoring won't reflect that. They're still going to be at a 4, okay? So just because they might have bumped up doesn't mean they bump up a GG score. Make sure you really know that scoring crosswalk, the scoring criteria, before you go bumping them up. Okay, know the GG definitions. So what is the difference between supervision or setup? What's the impact of parallel bars on gait scoring? Where do you score AFOs? Is that lower body dressing, or is that footwear? Same with a prosthetic. What's the impact if they need 2 people for a task to be completed safely? If you're using a stand lift transfer or Hoyer transfer, what do we do if they're tube fed for 100% of their caloric intake? Or if they use incontinence products, what does that do to our scoring of toileting hygiene? You need to know those differences so that we can be as accurate as we can be with this. And we do have on our website, as well as you might have, I know Robin and Tiffany, you guys have been around a long time. So there was like a GG orientation page, and we have all that information listed with that. If you want me to resend it to you, I'm happy to do that, just so that it's kind of all one package. And I probably will do that with the slides for this slideshow today. Remember that discharge scores of the 7, the 9, the 10, or the 88 can diminish our outcome results. So you want to make sure it's telling a true story. If they're really still not medically appropriate, that's one thing. Or if they don't have a car or whatever it might be, that's one thing. But if it's out of convenience, or you're scoring that because you didn't have a chance to look back through the treatment encounter notes and see if the assistant did have a chance to take them on uneven surfaces or look at socks and shoes, make sure you are careful when you're scoring the 7, the 9, the 10, the 88, so we don't accidentally diminish our outcome scores, okay? Okay, edit your story. Excuse me. Making sure that you communicate to avoid scoring an area as 7 or 88 when in fact your colleagues did look at that area. So what I see oftentimes is that toilet transfers are scored as 88 by physical therapy. It's all over the OT documentation, how they're doing with toileting. So make sure you've had a chance to communicate with your colleagues to make sure you get the best GG scoring available. We have a lot of communication pages that you can use. Even some of your managed care forms. I mean, I've got a form, but you guys can use what you have. When you're filling out some of those managed care reports, you can grab a blank one and make it generic and just at least have it as a communication tool from the assistants to you guys as evaluators, or from discipline to discipline. Fill out some of that information and share it with each other. Again, we've got resources on our website. I don't care what it looks like, but we just need to make sure we communicate and don't accidentally code something as 88 and not take the credit for the progress that they've made. Because then again, we're getting false information and our outcomes don't look as good. And then there's a lot of reasons why that, as I said previously, impacts us, from the nursing home compare site to CMS deciding where the bang is for the buck, and when people are deciding where they want to place their loved ones. For the MDS, 09 means not applicable, and that's defined as the person didn't do this task prior to their current illness or injury or exacerbation of illness. So scoring a 09, as I've mentioned before, I don't feel like that's really applicable for all of our assisted or independent living folks, people going home to the community, because they're going to need to get in a car to go home. And you know, it's just like anybody of you who've had babies, you want those nurses to tell you some really critical information before you go home with this new little life when it's your firstborn and you don't know what to do with it. So put yourself in the shoes of the family. If they don't have any background with car transfers and how to help this person safely maneuver that, that's kind of like sending you home with your newborn baby and no information. Granted, they don't come with instructions as it is, but we need to try to help our families at least do the best they can do to keep their loved ones safe right off the bat, which includes then at least one curb, one step, and some uneven surfaces, because nobody has perfect driveways and sidewalks to perfect little homes. So we really make sure you're looking at those areas as much as is clinically appropriate. And you can't tell me that somebody who drops a remote control for a TV isn't going to try to go for it. So what happens when they do? Let's at least look at it and score it, okay? Real important to not overlook those key functioning areas. Make sure to edit your story. So section GG isn't required. Remember, if the person's had an unplanned discharge, and that's touring to the hospital, if they've left AMA, or if they've died, or they had less than a 3-day stay. Section GG scoring done in error can then negatively impact some outcomes. And I did see some folks that apparently left AMA in the area that, you know, among you guys that I'm talking to. So if they've left AMA, you don't need to score it, and that can then maybe not water down the positive impact of your overall outcome picture. Does that make sense? I hope. So scoring 9 on an eval and scoring something later on is not necessarily logical, but you need to explain then that the discharge plan changed, because why was it not applicable before and it's suddenly applicable? Well, that may be a change in discharge environment. And as I said, breaking out those sections in Net Health can make it easy to have supportive documentation. For lower body dressing, there is an area for socks and shoes, toileting hygiene versus transfers, all that good stuff. Some tricky situations, and I'll get into some specifics for your buildings. You want to make sure you review the definition of each code and select the proper code for net health. Remember, if a task is attempted, the patient tried to do it, but they just couldn't finish it, then they're dependent. They're a GG score of 1. If it wasn't attempted, if it was a did not test, that GG code should explain why. And that might be the 88, the 10, the 9, the 7, okay? Selecting 10 for environmental limitations, like there is no car, it's a blizzard, it's a hurricane, it's whatever. Selecting 88 for medical condition, that they were not safe to walk the 10 feet. And I'm sorry about my typo being too short of breath. If your client didn't perform the task previously and it will not be addressed, then it's not applicable in net health and it would be scored as a GG 9, okay? And if they refuse, it's a 7. The one thing I do want to make a point about, some additional concerns, and that's not listed on the slide here, is that if a wheelchair is only used for facility convenience, they didn't use it before, they're not expected to need it upon discharge, then you can say no for that wheelchair question. So even though they're using a wheelchair in the building because the hallways are 500 feet long, or they're not strong enough yet to go that distance, you can score that as a no, and you don't have to provide that information. But if they did use a wheelchair previously, they're going to need a wheelchair upon discharge, then you would score that information for the wheelchair mobility, okay? So other concerns, so as I get, physical therapy is the one who gets responsible for coding toilet transfers, item pickup, or wheelchair mobility. When it's scored as 88 and OT has in fact addressed those areas, we want to make sure we've got a communication tool so we don't miss that. A person going home, as I've said before, is unlikely to never need to walk up and down one curb or uneven surface or transfer into a car of some sort. So having a POC goal in these areas from the get-go, when it's reasonable, and I know that there's always, but there's always people that are going to be wheelchair bound and that type of thing. But make sure that that you can have a goal so that the assistants are reminded to take that person outside, especially now that the weather's nicer. See if the family can stop by with their car and take a look at that, so that we can get a sense of how they're doing with those car transfers. Okay, make sure we're addressing all the areas of function. And again, I want to make a point that really we want to try to schedule a physical therapist and occupational therapist at least 30 minutes to be able to spend some thorough time doing that discharge assessment for the planned discharges so that they can really get a handle on how that person is doing with GG scoring and look over the treatment encounter notes that the assistant has written or the communication tool that you're using so that we're getting the best scores that are appropriate. Make sure that you're looking at coding accuracy because it's going to impact your facility outcomes. We've got resources on our website. Go under the employee portal. Under Arbor Rehab Education, there's a whole host of Section GG information, and certainly contact Tiffany with questions, myself with questions. More than happy to help as we can. I'm going to exit out of this, and as soon as that disappears, I'm going to minimize this, and I'm going to bring you guys back because I had to minimize it so I could see everything. So before I talk about your specific results of the things that I was looking at, do you guys have any questions at the moment? I don't. Nope. Okay. So I'm going to talk a little bit specifically. Now I'm looking at a different screen, so I apologize. Wait a minute. I do see the chat question, so thank you. So the question is, can we do a simulated car transfer if there's not a real car available? And the MDS answer would be no, that they don't want simulation. As a family member, so that's GG scoring. I'm saying no for GG scoring, but as a family member or as a patient wanting to have some clue of how this is going to look or how to best do it safely, I would say a simulated car transfer is better than no car transfer training at all, right? So for GG scoring, a simulated does not count, but for family comfort and safety, obviously it would be a tremendously beneficial approach, okay? So go for it if you can. So I was looking at some of the buildings specifically. I did look at some of the GG scores for some of the facilities in Tiffany's area. So I'm not going to call out any names. Again, I see some issues where sometimes what you have upon discharge scoring, the documentation versus the GG score is inconsistent. You wrote it up one way, but you scored them differently. I know the impact of phone calls and walking down the hallway. Please be careful. And also I do like, for example, at one building, I see good home exercise program goals for physical therapy. I think that's tremendous to try to help get people to carry over what they might need to know upon discharge. So I want to give a shout out for that. I want to be careful that if they're going 60 feet, for example, that you don't score them for going 150 feet. Or if they're only going 30 feet, we can't score the 50 feet. That has to be 88 potentially, or 9 or whatever else it is, 7 if they refused. But we can't score for an area that we didn't actually see. So if their gate distance isn't per the benchmarks of 10 or 50 or 150, we need to not be scoring those areas, okay? Also looking back at discharge summary information, again, or looking back at the treatment encounter notes. In more than one situation I saw, for example, a physical therapist had a person going 6, 8, 18 steps, but scoring for that area was limited, and they said 88 for 4 and 12 steps. It's like, no, right here in the treatment encounter note, the assistant did take them up and down more steps because they had a lot to deal with in the house. So again, make sure that you're communicating with the assistants, communicate with each other. I do see more than one example in more than one facility where actually we've made people worse according to our outcome scores, where they came in and maybe, generically, I'm going to say they all scored out at a 4, kind of that contact card assist level. And then by the time of discharge, they're in the 3s and 4s. And so your outcome score has gone down. And that's in more than one building and more than one discipline. So I don't know that that's a true story, because it's really unusual to me when I see they did great with OT, but they got worse in physical therapy, or they did worse in physical therapy, but got great in occupational therapy. Sometimes it's the reverse. So again, we just want to be really careful that we're showing a true story with our scoring, okay? Again, I think I've made the point about making sure I think we're going to be done in time. So we want to make sure that we're being accurate, looking at all the functional areas a person needs, making sure that the person has plateaued, not our skills, that we've really exhausted all the areas of function that person's going to need to cope with before they go home. Not just, well, I think we're done because we're, going 80 feet. So if they need to do more, that we need to do more. We need to think big with our goals and really think about what all areas do they need to function. Do we need to look at curbs and sidewalks and, socks and shoes and that kind of good stuff. So make sure you've got supportive documentation. Pretty much in a lot of the buildings, when I'm looking at GG scoring, it looks like you're pulling a number out of the hat for socks and shoes, or supine to sit, sit to supine. All that information, we need to have supportive documentation. I do see in one of our buildings, the physical therapist is writing goals now for picking up an item off the floor, which I love because it's going to remind all of us to address it. It's going to be documented, and then it's going to be scored accurately on discharge, more likely to be accurately scored. So thank you for that. I want to give a shout out to the PT who did that. Again, just be careful about scoring things that haven't really been looked at, or they've been looked at, and you're scoring them 88 when maybe they're eligible for a different number. So yeah, again, I want to put a note of caution out because I see both some physical therapists and occupational therapists have made people appear worse by their outcome scoring. And yet when I review the chart, they really weren't worse. Okay, so it's just scoring errors that I think can be a huge problem. And again, that supportive documentation. Remember to have a real baseline for things. If you're going to make a goal for stuff, have a real baseline. GG gives us some freedoms, I guess, that we don't necessarily have when we're writing up a plan of care in net health. So for example, if you want to have goals for picking up an item, walking on uneven, card transfers, and you don't know these things up front, then they're dependent or unable, and that's your net health baseline. And from there, they can go from whatever dependent or unable to min assist or whatever your goal might be. So you can do that, but you need to have a baseline documented in the eval if you're going to have a goal. Did not test doesn't qualify for a goal in the eyes of CMS, because their argument is you have no idea how they're really doing if you didn't test it. So we know as clinicians it's not logical, but we're clinicians and they are not. So let me just make sure I've looked at all my comments here, that I'm not missing anything that I would want to say. Again, just supportive documentation is so important, and thinking big with our goals. And yep.
Hey,
Okay.
Sandy.
Yes, exactly.
There
is something I've noticed. I have a lot of lower level people who require assistive too. And in Rehab Optima, when you hover over the different assist levels, the assistive 2 is under max assist, but on the GG, assistive 2 is dependent.
Yeah, yeah, you're right.
So I just wanted to mention it. I don't know if that's something that can be fixed in Optima, but I mean, I know it's there, so it's just one's max assist and one's dependent.
I know, and I hate that inconsistency in Net Health, and you would think that after over a year of GG, plus we knew GG was coming, that they would have worked out those bugs. They do have a whole different platform of Optima that we could have used, but it was so much, yeah, and it would be consistent, but it is all GG terminology, and that to me is way more restrictive than, and there was a lot of other things that made it a pain in the neck. So my suggestion with this, so thank you for bringing up the question, Jennifer, is that if you know this, just to maybe make a notation in the little piece of paper to the side, if you're going to code them as dependent, or you're going to code them as max of 2 in Rehab Optima, that you make a little pencil note, make a little notation that it was assistive 2 for safety. And that would then explain and justify why you've coded them as dependent on GG as opposed to scoring them out as a 2. Okay?
Yep.
That explains it to anybody who might question it. I appreciate the questions. Any other questions at this time? Because I know I've gone through a lot of information. No. So let me show you real quickly here, since we have actually like 5 minutes left, and I want to show you real briefly here some of the added resources on our website. And you guys know you need to kind of make sure, if you haven't already, and I know some of you have, but make sure that you catch up with the group and concurrent webinar and let me know that you viewed it. That's true. FRCs need to view that. And if you're evaluating therapists or treating therapists want to view that as well, that's fine, that's great. But I really for sure want to at least have the FRCs up to speed again with the group stuff. So there's a whole, under Arbor Rehab Education, there's a whole section GG tab. And when you're looking at this, this is some stuff that you might want to print off for your evaluating therapist, or, Jenny, you may want to take a peek at it if it ever pulls up, because it's going to have like the crosswalk. It's going to have some of the information about what do you, my computer's, my internet's saying, wait, I can't handle Zoom and a website. So that's really not going to do it. So again, what are we doing if they're in the parallel bars? So parallel bars are not a portable device. And so therefore, even if they went 15 feet in the parallel bars, you have to score them as dependent for 10 feet because parallel bars aren't portable. So that would be the answer to that. But that information is all here under the GG tab. That won't open. So, oh, there we go, finally. So again, there's handouts, there's the tracking, the one-day snapshot. Could be that communication tool that you use between the assistants and the evaluators, or that you could use among, among disciplines. The coding tip sheet, okay, is going to give you some of that information about where is the prosthetic, what's an AFO, where does this code out at. So you've got the resources right here, so that you can quickly look that up and make sure that you're scoring accurately. Again, that's going to be GG resources, which is underneath Arbor Rehab Education, down the left-hand tab here. You can print that out. Any other questions? Does this make sense to people? Do you understand why it's getting pretty important that we try to really fine-tune our GG accuracy between OIG looking to save money, between the outcomes that look like we're making people worse? And I do know that there's times that that's true, but if they're going to be going home, usually we don't send them home in worse shape than they came in, or they are leaving AMA and they are in worse shape than they came in, but it's AMA. We shouldn't be doing GG scoring in those situations, okay? So we just don't want to confound things and make it look worse than it is. All right. Well, if you guys don't have any questions, I do thank you for your time. Thanks for bringing in today. I will stop the recording and I will make this available, share it with you guys. Thank you for being my first Zoom attendees with this platform that I'm using, all the different screens and so forth. So you know how to find me if you've got questions. Enjoy the rest of your day. Have a healthy summer. Okay, people? Thank you. Okay, thank you. Okay.
Thank you.
Bye-bye.
Bye-bye.